begin by thanking the Monterey Bay Economic Partnership for inviting me here to talk about the challenges that healthcare providers are experiencing in the region currently, and particularly about what the potential consequences are of what's coming down right now from a federal level with respect to funding of healthcare and with respect to policy. So we're gonna jump in. Unfortunately, this is a very complicated topic and I've got a limited amount of time, so I'm gonna begin also by apologizing. We're gonna go pretty quickly. So the first thing I wanna do is talk about this observation that I think probably everybody's seen one way or another, and that's that the United States spends more on healthcare than other nations, yet achieves worse health outcomes. And again, I think most of you have heard this one way or another. It's usually represented by a graph like this, where on one axis is some healthcare outcome. In this case, it's life expectancy. On the other axis is expenditures per capita, how much we spend. In the United States is where the big blue arrow is. And you can see that our outcomes, or life expectancy on this graph, is pedestrian at best, but our expenses are huge outliers. And to just bring that home, it shocks people to hear things like there's parts of the country where health outcomes are terrible. The median life expectancy right now in Bangladesh is better than it is in most of Mississippi, to put that into context. So we're, certainly we're doing something wrong. There's some really strange paradox here. We're spending more, or we seem to be spending a lot more than everyone else, but our outcomes aren't very good. And usually people talk about this with respect to outcomes, and they talk about how do we get people healthier. It's our diet, it's exercise, it's violence, it's the social determinants of health. But what I'm gonna focus on a little more is how we kind of structure our healthcare delivery systems and how we fund those and how this all plays into this bigger picture. And specifically, I'm gonna kind of talk about 4 areas: how we pay for healthcare in the country, how we deliver healthcare, particularly in this region, why are expenses just dramatically increasing, and the consequences of all the kind of unfunded mandates and social service responsibilities that are being put on healthcare providers. And then we'll kind of go back and look at this chart. I'm gonna begin by talking about how things have evolved over the last few years, and then I'm gonna talk about what's coming down at a federal level. Again, I think everybody's heard about the One Big Beautiful Bill or the tax reconciliation bill. I'm gonna talk about the consequences of that. So this is probably the most information-laden slide I have, and I'm not gonna go through each column, but I think it's really important when we talk about healthcare economics, and many people are kind of surprised when they look at these numbers, but fundamentally, again, I'm sure everybody knows this, but healthcare administrators look at there being generally 4 buckets of payers. There's people who come in that have Medicare, and I think everyone knows Medicare is generally for people over 65. There's people with Medicaid. In California, that's Medi-Cal. That's usually for people under 65, individuals or families that are under a certain income level, so presumably they can't afford commercial insurance. There's those with commercial insurance, and there are those without any insurance. And just to jump ahead for a second, I can tell you virtually nowhere in the country, and certainly not in this region, are healthcare systems and providers reimbursed at the cost of providing care for either Medicare or Medi-Cal. So that's just a fundamental, truth that we'll dig into a little deeper. With the Affordable Care Act in 2012, the intention was to have fewer people that were uninsured. In the first column, those are in percentages, and again, you probably can't read all those numbers, but the intent was, again, to move people away from uninsured. And it was successful. I mean, we've had a dramatic reduction in the state and certainly in the region of people without insurance. We've had a dramatic increase in the people with Medi-Cal. Commercial insurance has gone down a bit because of affordability, as we'll talk about, and Medicare has risen just a little bit based on the aging population. As I've already mentioned, the reimbursement for Medicare and Medi-Cal is below the cost of providing care. And the numbers in the last column are American Hospital Association national numbers, but I can tell you for most of the hospitals in this community, we're reimbursed at about 75 to 80 cents on a dollar for the cost of providing care for Medicare patients and about 50 cents on a dollar for providing care for people with Medi-Cal. So with that background, when you look at Monterey County, and I know the region's a little bigger, but I think this is directionally accurate for the whole region. Most healthcare economists and hospital administrators would say, even though we all think of Monterey as being relatively affluent, this is a really challenging composition of payers. 50% of the people in this county have Medi-Cal. Most are through what's called CCH, Central California Alliance for Health, which is a managed Medi-Cal program. But roughly 200,000 people in this county have Medi-Cal. So it's 1 in 2 in the county. And on the Salinas side, we think it's north of 60%. So we also have a relatively poor commercial payer mix. We have about half the state average. We think we have a really good month if 20 to 24% of our patients have commercial insurance, and the state average is roughly about 40 to 50%. So this is a challenging environment to provide healthcare from an economic standpoint. And again, translating those numbers, I'm going to use Salinas Valley Health as an example. Each year, the cost of providing care for individuals with Medicare is about $90 million in the red for us. And the same with Medi-Cal. So I always say we start our fiscal year about $180 million in the red, taking care of the majority of the patients we take care of because they have Medicare or Medi-Cal. So, what does this mean for everybody else? And this is one of the many problems we have in healthcare right now, and it's fundamentally something called cost shifting. The only way that healthcare systems can stay open is from reimbursement from commercial payers, assuming you're like most of the healthcare systems in our community that take care of everyone. So we recognize it's an overwhelming burden on individuals and employers that are trying to provide health insurance or obtain health insurance. Again, because of time, we could talk about a whole bunch of other kind of perverse incentives in healthcare right now that were paid for doing procedures and not necessarily for keeping people healthy. And because of that, everybody wants to do joint replacements and have a heart catheterization lab and to do heart surgery. And it's all because we're trying to survive. But the reality is it doesn't decrease expenses. And actually, it's been shown over and over, if you have more heart surgeons, you get more heart surgery. It's not necessarily driving down costs. And actually, when you start spreading these kind of services over multiple places, the quality goes down. It's been shown over and over again in medicine that your outcomes are directly proportional to your volumes. You don't want to have your heart transplant in a place that does 1 heart transplant a year. So before I go on about the payer issue and the challenges we have, I just want to talk about how we don't get paid. I mean, we do have commercial insurance, but I think everybody's probably heard about this or had experience with commercial payers. Last year, United Health was criticized for denying about 25% of their claims. We have a huge infrastructure to try to figure out how to get paid. And nationally, the estimate is 15 to 20% of our expenditures are administrative expenditures just trying to get paid between claims and denials and adjudication and arbitration and really expensive electronic medical records to try to get paid. This is just a huge wasteful component of our healthcare system. A couple things about how practice models have changed. This is a question I get a lot. When I started 30 years ago, there were doctors in their office, there were independent practitioners. They come to an independent hospital, they might do surgery, they go back to their office. That is just basically obsolete throughout the nation and certainly obsolete in this region. Very few providers want to deal with the administrative expenses, the regulatory issues, their time and lifestyle and all kinds of other reasons. And there's been this transformation where if you go back to the 1980s, early 1990s, about 75% of practitioners were in these independent practices, and now 75% are either in employment models or contractual models. And this is a Salinas Valley Health chart of our clinic system that we've put together. This didn't exist 15 years ago. And I've got under regional, I say, we've done this very reluctantly. There's been this kind of perception that the hospitals have gone and bought practices so we could consolidate the market and increase prices. We have never increased prices. It's much more expensive for us to do this. It's very difficult. By way of example, the last group that came to us, there was a large pediatric group in Salinas that just called us and said, we can't survive. Will you take our patients? We said, we'll try to accommodate that. within weeks, they closed their door, and before we knew it, there were 50 kids sitting in the waiting room of one of our clinics because that's where they were told to go. So this has been, a real challenge in how healthcare systems have evolved in the delivery systems in our community. So really, the major healthcare providers like Montage and Natividad and us are providing the overwhelming amount of specialty care within this community, a huge percentage of the primary care, very few independent practices. We have a lot of Medi-Cal, which is served by some great FQHCs, federally qualified healthcare systems in this community, Clínica de Salud, Clínica para la Gente, Monterey County Health Department clinics. There are some concierge practices, and I think people know there's now an introduction of a single combined insurer provider system that provides great care if you have their commercial insurance. But as you can see in the economics from the previous slide, it makes it much harder for those of us who take care of everyone to cross-subsidize and provide care for everyone in our community. So why are healthcare expenses increasing so rapidly? Besides the new structure of how healthcare is delivered, there's just huge, we've done a terrible job in this nation in having adequate numbers of providers. I've seen numbers, and even in the last few weeks, there were between 80 to 150,000 providers short, or physicians short in this country. This is affecting access. We have to pay more for providers. It's really problematic. The squiggly chart on the right there shows MD granting programs in the United States over the last 40 years adjusted for population. We're really not growing providers as we need to. There's been osteopathic schools that have grown and offshore medical schools that have grown and PA programs, nurse practitioner programs, but we have huge provider shortages. And again, I'm sure you can't read the bottom chart here, but every 3 years we have to do what's called a physician needs assessment. We did the last one 3 years ago, and at that time, the Salinas Valley corridor alone needed 43 primary care providers based on our population. I understand Montage did the same thing. They had almost identical numbers. So 3 years ago, we were 90 primary care providers short. We're doing another one now. My guess is with attrition, particularly post-COVID, despite the fact that we've probably brought in a dozen primary care providers, we're probably a net negative right now. I mean, we have huge problems with access. I think everybody knows that other expenses are rising much greater than inflation. Drug expenses are running at least 10% per year. I think everybody's heard about the challenges funding GLP-1s. There's chemotherapeutic agents like what's called CAR T-cell therapy. One cycle of therapy is $500,000. I mean, drugs and technology are exploding, and historically in the United States, we funded development of these drugs, but we never got any benefit. I mean, only recently is CMS allowed to even negotiate prices for drugs. I mean, this is an area that just, it's just really an outlier. Electronic medical records. I keep saying this, if you're a standalone institution, you don't have one of the up-to-date electronic medical records in your system, you're probably not going to survive as a standalone electronic medical record system. And to just put it into perspective, in a medium-sized community hospital, to put something like Epic, the kind of gold standard for electronic medical records in your system, is well over $100 million. And then you start talking about cybersecurity and all the issues with AI, which some people think is either going to destroy us or save us, but right now I can tell you it's very expensive. The elements of AI, like the voice recognition, generative AIs that we're using in our clinics. The last big challenge that I'll mention is what I'll call unfunded mandates and social service responsibilities. And again, this is kind of a long discussion on its own, but there's always been this kind of ambivalence in this country whether healthcare is a right or a privilege. And in the mid-1980s, there was a lot of congressional testimony and discussion about this, as there were all these cases of people who would go to a hospital, they were dying, they didn't have insurance, they were told to go somewhere else, they died in transit. And because of that, the federal government passed a law called EMTALA, or the Emergency Medical Treatment and Active Labor Act, which requires hospitals to evaluate and stabilize patients regardless of insurance. So I guess the federal government said it's a right if you're dying, and that was the reality. And in the 1980s, when healthcare didn't cost as much and more people had commercial insurance, hospitals could subsidize that. Now it's very difficult and very problematic. Bunch of other unfunded mandates. There's this seismic issue. I mean, this is where you get into this complicated federal or state politics. Since the mid-1990s, there's been this requirement that hospitals upgrade from a seismic standpoint. 2/3 of the hospitals in California have at least part of their institution isn't seismically compliant. We're talking about probably north of $100 billion for the state. Senator Caballero sponsored a bill last year to waive this, at least for some time, as there's all these healthcare economic issues. It was passed unanimously in the state assembly and the state senate, and it was vetoed by the governor, probably because of political reasons, right? So these are just typical issues. I'm gonna the last point on this slide is social service responsibilities, which really also surprises people. Every Tuesday, I give a lecture to the residents and medical students at Natividad. And I asked them, usually I talk about infectious diseases, but this time I asked them a couple questions because I knew I was coming here. And I said, how many patients that are sitting on your service right now are just waiting to find a place to go? And they said probably half. It's estimated that 50,000 patients a day are sitting in hospitals in the United States just trying to be placed. And I'm gonna give a really harsh example and there's a lot of these, of unfunded mandates. There was this thing called the CalAIM movement in 2022 from the state, which had to do with reimagining Medi-Cal in the state and all these other things that Medi-Cal was gonna do. And one of them was this justice initiative, which made sense. I mean, it's well-intentioned, well-meaning, and the idea was that we're seeing a lot more aging population in incarcerated individuals with medical problems, and when they're being released, the idea was that we would make sure they had Medi-Cal before they were released and make sure that there was a bridge to community care. So all that sounds great, but we have two large prisons in South County, Salinas Valley State Prison and CTF Soledad, and let me just tell you how this is playing out. We got a call not that long ago, and all the hospitals are getting these calls, that there was a 68-year-old prisoner, history of heart failure, but very medically stable, that they were releasing. Medi-Cal hadn't been arranged, and they couldn't find anywhere for him to go because, unfortunately, he was a convicted pedophile. So they said, we're sending him by ambulance to your hospital. You need to find a place for him to go. So these are the kind of social service responsibilities that hospitals are now bearing. So, again, going back to the original chart and comparing to countries that outperform us, like Switzerland, France, Germany, et cetera, I'm fairly certain these countries aren't asked to place people who are just released from prison that no one will take. And when you start talking about the administrative expenses that we spend just trying to get paid, the other social service responsibilities, all the unfunded mandates, the fact that we subsidize drugs without any kind of financial benefit from that, all of these reasons, I think that actually if you kind of normalize for that, I think we're actually probably pretty good with respect to expenditures per capita, and I think we could use a lot of that money to improve outcomes as well. So I don't know who here has had the opportunity to meet Dr. McDermott, the new CEO at Montage, but Mike he's really good with these descriptive metaphors and similes. And when he talks about this, he says, everything we've talked about so far is death by 1,000 cuts, but he says, what's coming down from a federal level right now is like ripping a hole in the aorta. And for those of you who aren't medically inclined, that's really bad, so yeah. So let's talk about what's coming down now, right? So the one big beautiful bill, or I'll refer to as HR 1, was signed by the president in July of this year, and they took $1.1 trillion out of Medicaid. And as you can imagine, Medicaid's big in this region, right? And there were two ways that they were gonna decrease the funding. One is what they're calling disenrollment. They're trying to get people so they don't have any insurance fundamentally. And that's by two mechanisms. One is they're gonna make people re-enroll twice a year. And they know that each time you ask somebody to re-enroll, people fall off the roll, so to speak. They're also instituting work requirements. And one of the things I didn't mention previously that we'll talk a little bit about is because no one other than maybe the Office of Healthcare Affordability believes that any healthcare system in the country can stay open on Medicaid rates. There's all these supplemental funding, something called provider tax, something called Medicaid DISH, which we'll talk about. state-directed payments. There's some additional subsidizations that helps offset the cost, and they're dramatically decreasing those over the next few years. Additionally, as part of this, I think people have heard about this. This is one of the hot areas right now. If the federal government comes back that they're debating, is that one of the other things the Affordable Care Act did was for those who were above the 138% federal poverty level that didn't qualify for Medi-Cal but couldn't afford commercial insurance, there was essentially tax subsidization so they could purchase a product on the exchange, and that's to be phased out at the end of the year. And in California alone, it's estimated that 600,000 people won't be able to afford insurance, and since the insurers know that the people who are going to continue to buy insurance are the sicker people, there's going to be a dramatic increase in premiums, and that's apparently being released today, what the new premium schedule is going to be, and it's 100% more for many people. There's other Medicare cuts that are part of this that I won't go into because of time, and this is just a real simplification of a lot that's going on here, but the Congressional Budget Office estimated that we're going to increase the number of uninsured in this country by 11 to 13 million people. The California Hospital Association is saying close to 2 million people. And remember I said the big managed Medi-Cal delivery is CCH, Central California Alliance for Health. I'm actually on their board, and they're now modeling 20 to 25% of that 195,000 people are going to lose their insurance over the next 3 years. A couple of other things that aren't directly related to HR 1, but are certainly policy changes. One is something called DISH money, which is, again, funding that many hospitals get based on how much Medi-Cal they take care of. And this ended 10/1/25. And this is in the news. I'm not, talking out of school. This came up, at the Board of Supervisors discussion that Natividad, I'll read this little headline, significant funding worth $14 million annually to Natividad hospitals on the line. That is just this Medicaid dish. It has nothing to do with HR 1. And this is, ultimately going to come out of the general fund. This is fair. This is not sustainable, particularly when you start adding on to that all the other things that are in HR 1. And then, the last thing I'll mention very quickly is this Office of Healthcare Affordability. Our understanding is that 2 or 3 years ago, there was some pressure on some overhaul of how we're going to fund healthcare, particularly this discussion of a single payer system. And the governor, instead of looking at some comprehensive discussion, put together a board of unelected individuals that were given a lot of authority. They're putting spending caps in all of the hospitals in California. There's below inflation. And if you adjust for inflation and you look at those spending caps, we're talking about taking billions of dollars out of providers, healthcare providers, hospitals in California. That really doesn't fix the underlying problem. Again, each one of these topics deserves a whole day symposium, and I'm not going to go into them. But from a policy standpoint, there's a lot going on with respect to science, education. CDC is being destroyed. The NIH, which has funded, the overwhelming amount of drug development in this country, something like the last 50 major chemotherapeutic drugs were either developed at the NIH or funded by the NIH. The NIH is, problematic right now. The information we're getting about vaccines through HHS and the CDC is problematic. In a whole discussion about this immigration issue, in California, you do not have to provide proof of, you don't have to document your immigration status to get Medi-Cal. That's actually going to start getting constricted in January of 2026. And, I'm not sure you can see the numbers down there, but Central Coast Alliance for Health, of the 195,000 people they have, 45,000 people are undocumented. And when I said they're talking about a 20 to 25% reduction, that doesn't even include this number. I mean, this is a huge issue in our region. So what are the consequences of all this? We're expecting a significant increase in the number of uninsured. We're going to get paid less from those with governmental or commercial insurance. We're expecting to see people that are sicker because they can't get into primary care. They're going to come later. Once they get there, we're going to have huge challenges in placement. I think there's real uncertainty as to the viability of many of our surrounding systems within this region. Again, it isn't out of school. Watsonville basically is looking for a partner. The current model isn't working. I think we're going to see much more consolidation eventually. And I'm going to talk about it, but this is an amazing community, and I think we're going to lose some of that community vision. I think we're going to see more equity gaps as people without insurance aren't going to get care, and people that can afford commercial insurance from a provider that only takes care of people with their commercial insurance, it's going to make cross-subsidization much harder, and I think that's going to be a problem. And lastly, these large healthcare systems are some of the major employers in this community. We employ over 2,000 people. We insure over 5,000. This is going to be potentially a significant job loss throughout the country and in this region. Okay, so I always put this slide up. I should have mentioned before. So whenever I talk about healthcare economics, my wife is like, it is so depressing. And she is one of our internists. She's here. So I always put up my unicorn and rainbow slide and try to say a few good things, right? So, I think Monterey County, you guys hit it on the head during that survey. Access and expense is just a huge, huge problem. But I think, this is a pretty amazing place. All of these healthcare systems, I always say, they're owned by the community. They're all non-for-profit. We work together. We try to take care of everyone. I think we're all mission-driven. I think it's a pretty amazing place historically. And I've talked about this before, so some of you have heard this in a different context, but I think the perfect example was what happened during COVID, where the hospitals worked together, the health department worked together, ag, business, non-for-profits, and we took care of everybody in our community. And a really strong objective measure of that is death rates. And if you look at, this was from a publication from the CDC, and kind of as the pandemic was ending, and you're looking at deaths per 100,000, many places in the country were running 400 to 500 deaths per 100,000. California did better. Monterey County did better than almost any place in the country. We had 195 deaths per 100,000. Yeah. It was really pretty remarkable how we came together and did a fantastic job. And this last slide, move on. So what are some solutions? And again, I don't think anybody's got any definitive solutions here, but I think a discussion at a national level, a state level, local level about meaningful payment reform, just saying hospitals can't, price even with inflation for commercial rates isn't going to fix this. It's not going to do anything. We've got to really kind of look at this in a much more comprehensive way. I think we need meaningful state legislation. I think what comes down from the state is well-intentioned, but it doesn't factor in how healthcare is delivered now, and these unfunded mandates aren't going to help anything. I think there needs to be a huge investment in workforce. I think you may even hear about it today. UCSC is working on a medical school, which is fantastic, and Cal State Monterey Bay is working on an PMPA program. I can tell you the numbers of people that are talking about putting out are a fraction of the needs. We need to invest in this. So this little, thing I have here is kind of the Salinas Valley Health banner or tagline that I think applies to all of the healthcare systems in this community. Quality healthcare delivered locally for everyone. I think that's been what we've done incredibly well, and I don't think there's going to be any white knight that's going to come in and rescue us. And I think within the limits of what we can do legally, I think the more we can work together, collaborate, share information, we can continue to provide the incredible care that we did during the pandemic and that we can do going forward. And I think it's just, really pretty special what we have here. And I think it's clearly in jeopardy. And, again, I'm hopeful that we can continue to provide what we've provided historically. So thank you very much. I appreciate everybody listening. And that's it. Thank you.
You got it. Thank you. Thank you, Dr. Radner. Really appreciate it.